Hi, everybody. It's 7:30. We will start on time. My name is Amanda. I'm a consultant at the Children's Emergency, and I'm also Deputy Director for the Center for Sustainable Medicine at NUS. So this morning, we are very happy to have with us actually the speaker, not me. I know on the slide it looks like I'm speaking, but really I'm introducing Nick. Nick is the Director for the Center for Sustainable Medicine, and I have the pleasure of introducing him. So he comes from his role as Chief Sustainability Officer at the NHS in UK. There, he was responsible for leading the National Delivery Team and the NHS Sustainability Board to guide them to become the first net zero health system in the world. And he oversaw the establishment and significant expansion of the national program, the embedding of its work to national healthcare legislation, and has secured over $1 billion in funding for net zero healthcare. Prior to this, he actually came from the Lancet Countdown. He was the executive director of the Lancet Countdown on health and climate change, and he built a multi-center research collaboration across 51 academic institutions and UN agencies dedicated to tracking progress on health and climate change. He's trained in medicine and public policy at UCL and University of Western Australia, and is a fellow of the Royal College of Physicians, Faculty of Public Health, and an adjunct professor at the University of Notre Dame and at Monash. He founded both the Global Climate and Health Alliance and the UK Health Alliance on Climate Change, which are dedicated to strengthening the health profession's voice in the response to climate change. So that is the stuff on script. But Nick has been here for about almost a year now in Singapore, and he has been already quite influential in shaping the space of net zero medicine, sustainable healthcare here in Singapore and beyond. So without further ado, let's welcome Nick on stage, please.
Is this working? Outstanding. Hello, good morning. How is everybody? Yeah, you will be, don't worry. Okay, listen, it is 7:30 in the morning, hey? I understand there's breakfast outside, I understand there's coffee outside. We're gonna run a little bit short and a little bit quick because, God, people have got things to do with their day, and I'm sure everyone always forgives a speaker when things run a little bit faster. Amanda was obviously supposed to be presenting here, so if people have questions, difficult questions, hard questions that are really, you know, jarring questions, direct them at Amanda. Is that okay? I'm going to talk a little bit about how this space has evolved, but I think more importantly, most importantly, where we are and some of the myths that we start to face. This space, the sort of links between climate change, healthcare, it's been around for a while, hey? First paper in the British Medical Journal, 1988, the Lancet, 1991, sort of slowly leaves the realm in the 90s, 2000s of sort of advocacy where, frankly, it's a bunch of climate hippies wearing Greenpeace t-shirts, shouting about stuff. It leaves that world pretty seriously in the sort of late 2000s, early 2010s. You start to see mainstream healthcare bodies really start to take this seriously. That mirrors a big blast of evidence that starts to come out. We went from a period of time where there were 10, 20, 50 studies published on this topic per year back in the sort of early 2000s. We're now at the space where it's about 1,000, 2,000 and growing, doubling every 2 years or so. This space is growing very quickly. It moved from that advocacy space to that evidence generation space. And I think just in the last couple of seconds, it's moved into the delivery space. People aren't asking anymore, is climate change a problem? People aren't asking, should I do something about it? The answer to both of those questions is pretty damn clear. It's yes. People are asking, what should I do about it? People are asking, how far should I go? How fast should I go? And those are pretty legitimate questions, right? They're delivery questions, and thankfully they're questions that medicine and the evidence we generate is pretty well equipped to handle. As you move into that space, though, you bump into a bunch of myths. Over the last couple of years, I've heard a few, and so I thought I might talk through some of those. The first that you hear again and again and again is I would do something, but we don't quite have enough data yet. Could we do 7 more studies, 8 more studies, just a little more to just get a better sense of what the problem is? I think we're well past that. I think if you want to take a look at a standard hospital, at a standard cluster, at a standard healthcare system, you can see that the hotspots of where the carbon is across each of the sort of identities that we work with are basically the same. You will find that between 5 to 10% of emissions come from transport, how we move goods around the system, how we move our patients around the system, how we move ourselves around the system. You will find that 10 to 18% of emissions come from the buildings themselves. That stuff's pretty simple. It's from either the lighting, the heating, the cooling, from the appliances that we're using, from the electricity that we're purchasing. You will find that between 20 to 25, sometimes up to 30%, I suspect in the case of a country like Singapore, a little higher, come from the medicines that we prescribe. You will find that another 20% or so come from our sort of complex medical devices, anything from a harmonic scalpel through to an MRI machine. And then you'll find that the remainder come from boring stuff, bottles of water, pieces of paper, chairs, tables, that kind of stuff, right? We know what the rough shape of a healthcare system looks like. We know within an economy, it tends to be about 5, 6, 7% of emissions. Singapore, you do a big macro estimate, it looks like 4.1% of the country's emissions profile. Broadly standard. We also know that a lot of the interventions tend to hold true across different contexts. We know the first 10 things you should do to reduce emissions within a healthcare system. We know the first 20, 30 things. We know that even kind of without properly assessing it, it's a pretty good bet that if you are taking a meso-complex device like an endoscope and you are entering into a circular reprocessing chain rather than something linear where we buy it and throw it out, that is broadly going to save you money and it's broadly going to save you carbon. That's been studied again and again and again, and should always be restudied within a local context. We should always check that. But we've got a whole suite of interventions there available to us. I think we have more than enough data to run at this problem. And anytime we are worried we don't, well, good. That's an excellent quality improvement project to check that that's the case. And if it's not, figure out a way to pivot. The second myth I think you run into, and a lot of these things I honestly think come from people who genuinely are pretty well meaning, are actually quite interested in this space, but have just bumped into them and maybe haven't had the time, headspace to properly go and look at some of the literature. It costs too much. I hear that a lot. If you stop and think quite seriously, it's always worth that, about what it is that we are talking about when we are talking about reducing the emissions of healthcare, the only stuff that adds serious capital pressure, serious cost pressure to a healthcare system, think about it, is going to be the purchasing of either a new fleet of electric vehicles. That does cost money. The cost of an electric vehicle relative to its diesel counterpart, depending on the kind you're buying a van, it gets a little higher. It's about 1.2 to 1.5 times the cost of its diesel counterpart, of its non-electric counterpart. The good thing is it runs damn cheap. They pay for themselves in every high-income country. A standard electric vehicle pays for itself now in 1.5 years, paying back that 1.2. For a van, it takes a little longer. That takes about 4 or 5 years. 4 or 5 years for a van in a healthcare system, that's about the lifetime of that van. We run, obviously, our fleet faster and harder than a residential fleet might. That costs a little bit of money. It costs a little bit of money to manage some of the energy efficiency measures, the on-site renewable generation, some of the clever things you want to do with cooling and with heating of your buildings. That does cost money. For the NHS, we thought it would cost about 2 to 3% of the total capital budget per year. 2 to 3% is not nothing, especially healthcare systems who are often capital constrained. Not so much a problem in Singapore, but still a genuine barrier. The good thing there is you have some very, very expensive things that you have to go and do. Anytime you mess around with HVAC, anytime you mess around with cooling, that gets expensive very, very quickly. And you have a whole bunch of really quite cheap really quite cost-effective interventions. This number won't quite be true for Singapore because its energy efficiency standards are much, much higher than you see in the United Kingdom. But when we looked at everything we wanted to do for the UK in our built environment, we thought it would pay back within 3.6 years on average when we added absolutely everything up. It was that calculation that led to the NHS investing billions of pounds into its decarbonisation effort. It's not because they suddenly woke up and decided they cared about the polar bears or the trees. It's because it made damn good business sense. You hear often that there's not enough data. You hear often that it might cost too much. You also hear, I think, that it might distract from some of the core work that we do as clinicians. I think if you really push me, I can maybe envisage one or two situations where you might find someone who cares about healthcare decarbonisation at odds with clinical outcomes and clinical ends. But I have to get pretty damn wild and imaginative and creative. I actually think almost all the time, when you look at it, you go, well, what do you want if you want lower carbon healthcare? You want care to be situated in the right place. You don't necessarily want to be bringing people in and out and all the transport emissions, all the inefficiency as they bounce in and out of a tertiary center. You want to be making sure that you are able to provide care in the appropriate place. That probably, as we enter into a sort of shifting demographic, is care closer to home. It's probably care closer to the community. And every time anyone has checked in Germany, in Austria, in Canada, they've seen that the emissions there are significant emissions reductions attached to virtual wards, hospital at home, and community and primary based care. You probably want to ask that question of that poor houseman, do you really need that 17th CRP this Friday? And the answer is probably no, we don't need the 17th one. You probably want to focus on good medicine, on high value care. You want to make sure that we are not doing stuff that just by its very nature is wasteful, cost-wise, harmful to the patient, and obviously then wasteful for carbon. Almost everywhere we look, whether it was new green space for our stroke rehab patients, whether it was providing some of that care closer to home, whether it was making sure that we were able to get some of the medications to our patients much, much faster by drone, by bike, than we otherwise would by truck. It turned out that pretty much everything we wanted to do was actively good for the patient. It turned out when you want to talk about mental health, you should go and talk about physical activity and healthier diets and social prescribing. Far, 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 far more effective than pharmacotherapy, right? I think the fourth myth, and this isn't so much of a myth that's out there, but the fourth thing you hear again and again, and fair enough, is that staff are tired. Staff are tired. So this one I don't think is quite a myth. People say, God, I've just come to the end of a 12-hour shift. You can't seriously expect me to go and do just a little bit more in the sustainability world. I'm pretty damn tired. And I think to the person that says that, the response should be, yeah, fair enough. Go home, have a rest. There's something interesting, though, that we started to find in the United Kingdom. When we went out and actually asked people, we ran representative polls across the country. We ran them every 3 months, in fact, and said, hey, what do you care about? The response from the 1.4 million healthcare professionals in the NHS was thunderous. 92% of healthcare professionals wanted to work for an NHS, wanted to work for a healthcare system that was responding to climate change. That number is from 2019. I remember through 2020, 2021, I was pretty nervous because I didn't really want to go and ask that question again. I didn't really want to go and poll healthcare professionals again because I was worried that that number would go down. Fair enough, healthcare professionals were busy throughout 2020. In June 2020, it went down 1% to 91. By the end of the year, it had bounced back up to 92, and then into 21, 93%. What we had forgotten is that if you give healthcare professionals, you give doctors, you give nurses the opportunity to shape the future of what their healthcare system looks like, you give them something exciting to do, it's not tiring, it's energizing. It's something that gets people up in the morning. We actually find across the United Kingdom, this gets used primarily as a way of differentiating our trusts and hospitals to make them more competitive and attractive to their staff. There's a great story about a hospital in the North Midlands that was competing with another hospital in the West, in Bristol. They both wanted to hire this excellent anaesthetist who was going to come along and be their sort of head of anesthetics, head of their anesthetics department. The hospital in the Midlands was more prestigious. It's bigger. The pay was better. It's got a more impressive sort of clinical research unit. The job looked, for all intents and purposes, easier for the anaesthetist, and they ended up deciding to go to Bristol. They ended up deciding to go west. And the chief executive called up the anaesthetist and said, "What the hell, man? What's going on?" And they said, "Well, listen, Bristol was the first trust in the United Kingdom to declare a climate emergency. It has one of the most ambitious targets. And the chief executive there said, if I come, I can be part of shaping the future of what anesthetic practice looks like in the United Kingdom and around the world. And that sounds pretty exciting for me. I'm halfway through my career and I want to make sure that I stay at the forefront of this." And so the chief executive from Manchester turned around and came to us and said, "Well, shit, I just got beaten out. How can I make sure this doesn't happen again?" 6 months later, you see Manchester starting to lead the way. 100% of its ambulance fleet, 100% of its full fleet now fully electric, solar panels, kind of literally everywhere you look. So you hear a lot that there's not enough data, that this stuff costs too much. I think there's more than enough data to start running at this. I honestly don't think that this costs too much. I think when we look across the long arc of an economy in other sectors, we see the opposite. Good example of this is 20 years ago, the OECD estimated that the response to net zero, the response to climate change to get a 50% reduction in global emissions by 2050 would cost 2% of OECD GDP. When they came back and checked that in 2022, they said, really interesting. We actually now think not just to get to 50% of the way, but to get the whole way to net zero by 2050 now only costs 2%. So we'd gone halfway through the journey and the costs had halved. In effect, the transition had paid for itself. What's happening there is you see that electric vehicles cost a little bit more, but then the cost comes plummeting down. You see that solar, initially, sure, totally did cost a little bit more, but the cost now is competitive, cost advantageous against coal-fired power in literally every country in the entire world. There's nothing inherent. You will hear every now and then, I used to hear all the time from pharmaceutical companies, from medical device companies, from the med tech sector, that we would love to give you this green drug. We would love to give you this green whatever. It'll cost about 11% more. Is that okay with you? The response from healthcare systems, certainly the response from the ones that are starting to run at this, was and should continue to be, get lost. There's nothing inherent in green chemistry that means that it has to, at a physical level, cost more. There's nothing inherent in circularity that means that it has to cost more. Quite the opposite. Bit of innovation, absolutely a bit of innovation cost, and we've got to invest in that. But out the other side, our sector should follow every other sector, should follow the power generation sector, the built environment sector, transport. This stuff will run at cost neutral. So I don't think there's as much of a data problem as we talk about. I don't think there is as much of a cost problem as we talk about. I think when you look seriously at it, the majority of what you want to do to respond to climate change is directly aligned with the care we provide for our patients. And I think when you turn around and you say, hey, I know you're tired, but how do you feel about a lower carbon healthcare system? Would you like to be a part of running at that? In the United Kingdom, now 93%, in Austria, 89%, in Canada, preliminary data, but 86%. In Singapore, we ran our own numbers, 84%. Those are my first 4 myths. I've got one more. And then has everyone been preparing some incredibly difficult questions for Amanda? Outstanding. The final thing you sometimes hear is, well, listen, fine. I believe you that we can run at this. I believe you that we can take some first steps, that the cost may not be quite as hard, quite as high as everyone has been saying. I believe you, in fact, that this might even be aligned with high value healthcare. I believe you that this might energize staff. But I just think it's too complex. I just think it's too hard. I just think it might be beyond what a healthcare system, what we are able to quite manage. Anyone that says that the response to climate change, that delivering a net zero healthcare system is too hard, has not been paying attention. They should get out of the way, quite frankly, of the people that are already doing it. In the United Kingdom, emissions have already fallen by 56% in the NHS. It's just quietly been getting on with it. You see that mirrored right the way across the OECD healthcare systems that are starting to run at this, picking up pace. Yes, they've hit the low-hanging fruit first. And yes, things are going to get a little bit harder as you get a little bit more complex. But 4 seconds ago, there was only one healthcare system in the world that was running at this. Then there were 11. Then there were 28 healthcare systems, national healthcare systems, committing to run at this problem. You see all the way across Singapore, the space has exploded. Don't tell anyone in any of the other clusters, but the stuff happening here, infinitely more impressive than anything I've seen, quite frankly, in almost all of the hospitals across the world. Some of the stuff that NUHS has been doing, if you go and spend a little bit of time talking to the team, I can see sort of gathered just over there in the front. It's damn impressive. Anyone that says that it's too hard, we don't have enough data, it costs too much, it might not be aligned with good clinical outcomes, they haven't been paying attention. They need to get on board with the inevitable direction, the inevitable future of healthcare. I think that's the question we're asking now, not will we get there, but when will we get there, and is everyone ready for it? Difficult questions directed to Amanda. Thank you very much, guys.
Seriously, are there any questions for Nick? or for me as well? Sorry.
Can I ask you a question around what you think you've seen in Singapore over the last 5 years in this space? So I feel like around the world it has sort of exploded. Has that been true? Can you reflect on where things were 5 years ago and where things feel like they are now?
5 years ago, I was a senior resident doing my sort of scrappy QIP, applying to equip to get it approved as a QIP. I was told it's not a QIP because reducing waste isn't actually quality. And for the most part, I think today we probably see a slightly different landscape. I think there is much more groundswell. There's much more ground-up initiatives. If you look around, there's actually been practically every cluster, even private healthcare system, at least in Singapore, has started to respond to this both from the ground up as well as top down. The fact that Prof. Eugene has now been appointed Chief Sustainability Officer is proof that at least at the governance structure level, there is already change that's happening. So I think there has been actually quite a lot of change just in maybe the last 2 to 3 years. The fact that there's been significant investment by the university in this Center for Sustainable Healthcare, Sustainable Medicine, is also proof that I think there is a tide coming. And Singapore being always quite big on sustainability and having significantly serious net zero ambitions, I think is also testament to the fact that there is something different happening in the last few years.
I was told I was supposed to talk a lot about what the Center for Sustainable Medicine was going to do. I didn't, did I? Yeah. Would you like to, or would you like me to? Yeah, great. Okay. Look, there you go. There's a logo down the bottom there. Maybe to pick up where I started, hey, this space has existed in the advocacy space, moved into the evidence generation sort of space at the public health epidemiology sort of level, and then it charged into delivery. People started going and actually doing stuff in clinic, in healthcare, on ward. I actually think we got there, frankly, a little before we were ready. I don't think I see the army of sort of clinical academics across the world that you need to make sure that this transition is successful. I don't think I see the evidence generation at quite the scale that we're at. I used to sometimes say when I was at the NHS, we felt like we were implementing currently 100% of the things that we had evidence for. That's not to say we were going beyond the evidence. That's to say that in a couple of years, if people weren't starting to build that pathway out, we were going to be in a bit of trouble. And so that's what the center exists to do. It exists to partly run some of that training. And so you'll see from us new fellowships, graduate certificate, a master's program, PhD program in this topic. You will see new research projects starting to pop up, both at the product level, what is the emissions of this scalpel, through to the system level, and work looking at what the emissions profile of an entire healthcare system in Singapore looks like, but then further, what are the sorts of standards we would expect to see integrated into some of the big funders like the Asian Development Bank. You'll see both of those things out the other side. And really what that is about, what that transition is about, I think, is shifting from the talking into the doing. And as you do that, you've got to evaluate the interventions. You've got to make sure that some of those cost savings I'm talking about are real. You've got to make sure that the patient outcomes are exactly where you think they should be, that things are getting better, or at the very least, you're at clinical equipoise. Yeah. Eugene, can I ask you a question? Sure. What are you, in the next 5 years, most excited about, and what are you most worried about? And I guess I'm mostly interested in the latter, but I thought I'd ask the former too.
I think we're most excited about how we can definitely build greener and also work greener.
Yeah.
And so there are a lot of ground up ideas, in fact, which have very, very good outcomes and actually save both money and costs. So that's the plus side. I think on the downside, or the what scary side, is whether we're working fast enough.
Yeah.
And it's quite ironic that I think about the time of the Kyoto, I think 2 degrees C was seen as the worst case scenario at that time. Whereas at Paris, 20 years later, 2 degrees C is now seen as the best case scenario. And that's the frightening thing, is how fast things are changing.
Yeah.
This news today about air turbulence might be, what the flights go through could actually be due to climate change.
Yeah.
And so it's a mixed feelings of both, we have to do a lot, and but are we doing it fast enough? So that 4 degrees C doesn't become the best case scenario 20 years from now.
I feel that way, hey. I mean, the unfortunate answer is, are we going fast enough? No, not yet. And I worry that may always be the answer. And so in some ways, if that is going to be the answer, you have to remember, obviously, that 2 degrees is bad, 2.1 degrees is worse, 2.2 degrees is worse. So these numbers are in some ways political constructs. Everything we're doing to slow that or to bring it down, always better, but never fast enough. I remember around the time of some of those numbers, everyone used to talk a lot about these big heat waves that you would see, that we saw in 2003 in Western Europe. 71,000 people died. It was a big freak event. At the time, we didn't quite have the climate sort of methods to be able to assign any kind of attribution, any causality to climate change from that event. About 20 years later, we gained the ability to do that. Some clever new scientists that I reckon are in line for a Nobel Prize, running something called a detection and attribution study. They did that. They said, well, this looks pretty scary, but this looks like at the order of sort of 70,000 deaths, heat wave deaths across Western Europe. This looks like the kind of thing we might expect once every 100 years. or so under a 1.5 degree world. 2 years ago, and this is some new stuff that just came out from Copernicus, from some of the satellites over Europe. 2 years ago, 58,000 deaths from excessive heat in Western Europe. Last year, 63,000 deaths. Two particularly fiercely hot years. Now, heat in Western Europe means something very, very different to heat in Singapore. But what that tells us is the impact, not necessarily of the extremes, but the impact of change. When our systems, when our buildings, when our healthcare facilities are not ready for that level of heat, very, very quickly things kick into, getting overwhelmed. It turns out we do exist in quite a stable level of homeostasis there. So I feel that way, Eugene, right? That the emissions are not coming down fast enough, temperatures are rising, but we are also moving from talking about sort of future impacts to talking about stuff that happened last year, 2 years ago. Those are pretty serious numbers if you were France or Germany or the United Kingdom.
Any sort of burning questions you can, oh, there's another question.
Hi, sorry, Mark here.
Mark.
Actually, the interested people in these issues, a lot of them are here.
Yeah.
And we've got pockets of very motivated people like Becky here. But do we think we've really caught on? Have we got traction yet? And if not, which I think not yet, right? How are we going to get it happening?
What you got, Amanda?
I think that's kind of why I think our center still will have a job for a while. I think in some ways what you mean by traction, on the one hand, there is interest, and the other would be opportunity, and the other would be sort of leadership to move forwards. And I think that the interest is growing. I agree that it's still, somewhat, I wouldn't quite say fringe or periphery. I think things are getting mainstreamed a little bit faster than I suspect, is perceived, mainly because I think a lot of work is actually happening behind the scenes. In terms of capacity, I think that is where institutions will need to actually properly invest in it. And I think, like what I think Nick has alluded to earlier on in his talk, I think what the center exists is to actually help build that capacity by upskilling people in the space, not just the healthcare professionals who are here, because ultimately we are trained as, doctors, nurses, what have you. We do need other skill sets from other parts of sustainability, other parts of like built environment to come to the fore. So I think we are quite excited about that, and we do hope to contribute substantially to that. And then at the leadership level, I think things are moving, from the ministry perspective. If I may be slightly vague about that, but yeah, so at the ministry level, I think that there is interest and just about getting organized. Yeah,
I would agree with your assessment of where things are at, and I actually don't know if, I think I would feel that way if I was in pretty much every country. I would feel that way if I was in the United Kingdom as well. One of the challenges you run into in healthcare, distinct from some of the other sectors, if you think seriously about, okay, if I'm a transport system as an end use sector, what are the interventions I need in place to run at? Well, they're actually fairly simple. You ask three pretty broad questions. Does that journey need to happen? If it is going to happen, does it have to happen via that mode? So can the journey happen at home? Can the journey happen in community? Do you have to travel to the other side of the country for something? If you have to travel, can you travel by public transport? Do you have to travel by plane, etc.? If you have to travel and you have to travel through that mode, what fuel are you using? Can you use electricity? Can that electricity be decarbonized? Relatively simple. And when you think about the category of interventions, big things you do, electrify a fleet, right? I'm obviously grossly oversimplifying, but the category of intervention is quite large. I think in healthcare, one of the problems we face is we don't have big things like that, big silver bullets. I think partly because healthcare is so diverse, the experience of being a community OT is just so fundamentally different to the experience of being an intensive care doctor. They have almost nothing in common, right? The intervention options for us are just as diverse. And so what it means is we have lots of little bitty solutions, which from a change management perspective is pretty challenging. Where I think I see clinicians and examples of things that have done really impressive jobs and started to run at this stuff, I think they do three things. I think number one, and this is where the anaesthetists are annoyingly efficient, they identify tribes of people and they band together, right? They identify a tribe, a group of people they can call their team, something their team can uniquely act on, anesthetics, Des Lorraine, asthma nurses, MDIs, intensive care nurses in the United Kingdom, and plastic IV and excessive use of PPE, right? And then they start to run it. I think the second thing they do is they right-size their intervention. So they don't say, I want to deal with climate, I want to deal with, emissions in a healthcare system. I know I'm going to run at all of coal-fired power in the entire world and try and stop India from constructing 1,800 coal-fired power plants, bit silly. They look at something within the sphere of their control, look just one level up. And then I think the third thing that I see when people are successful is they go and evaluate it. They go and evaluate it seriously. They demonstrate that those savings were real. They demonstrate that they're not often enormous, those cost savings and those patient benefits. They're often quite modest if you're doing it at a ward level. If you scale it to a hospital level, to a cluster level, to a system level, this stuff starts to add up. But I think when they find their tribe, when they right-size the intervention and when they evaluate it, those are, whenever I look around and say, where have people managed to take this from individual couple of passionate people to something properly scaled? Those are the three things I think they've done well. I'm so sorry, though. I see someone glaring at me in the audience and I'm going to have to leave. So I may have to say, if it's okay, moderator, that we might have to close for questions. Is that okay?
Thanks very much, Nick. And thank you everybody for coming down for this morning's grand round. We're happy to have any questions by email or just drop us a text. Thank you.